talk about the super knee procedures. This is a procedure that I developed in 1996 for the first time. And as I told you last time, super refers to systematic utilitarian procedure for extremity reconstruction. And, you know, really, these are systematic procedures through a single incision that's pretty utilitarian. And, you know, the super, actually, the super knee was 1994. I'm mistaken here. The super ankle was developed in 1996, and then the super hip was 1998. So the 1990s was a super decade for me in terms of, you know, coming up with these new reconstructive procedures. So this is, last time we talked about a lateral incision, and that incision goes in a straight line along the lateral aspect of the thigh in the mid-lateral area, and then it reaches just below the tibial tuberosity. And we're going to talk about different scenarios. And, you know, unlike the super hip, there's really many variations of these utilitarian knee reconstruction procedures, and they're all lumped in to the super knee. In the super knee, I borrowed from several different knee procedures and combined them together into a conglomerate procedure. So the super knee is really a conglomerate of other procedures, some of which I designed, some of which I did not originally design, but I borrowed. So let's start when the patella is normally aligned, then we'll move to when the patella is maltracking, and then we'll move to where the patella is dislocated. So this is a spectrum of disease. And these are typically congenital femoral deficiency cases. And when the patella is normal, is the first step. And you can see, by the way, this is the appearance of the incision from the front view. That's why I say it really is a straight line. It's, you look on the lateral and you say it's curved. That is just a perspective appearance. If you look from the front, you realize it's a completely straight incision. And so when the patella is normal, we're going to reconstruct the knee ligament. So what's the indications here? Either symptomatic or significant instability of the congenital femoral deficiency knee, where you feel that it is indicated to reconstruct the anterior cruciate ligament and stabilize the AP and rotatory instability of the knee. Okay, so for that purpose, we're going to do a notchplasty, and we're going to do ligament reconstructions, both intra and extra articular. So the first part, and I showed this last time, we elevate a large flap of skin up to the midline, or up to sort of adjacent to where the patella lateral border is. Remember, the patella is located and normally tracking in this first example. We elevate a little bit of the posterior flap, and then we find the anterior border of the iliotibial band, and this should be at the junction with the patella. So this is essentially almost like a lateral release of the patella incision, and you open it there. You open it more proximally. How proximally? You notice I'm using a tourniquet here. This is a type of tourniquet we use called the HemaClear. It's originally designed in Israel, and it's just a strip of silicone that with stockinette is wrapped up on the thigh. I guess you can use whatever tourniquet you want. The problem is you want to use something fairly narrow, something that doesn't take up a lot of space, and that's the advantage of this tourniquet. You need to get up to the muscle tendon junction of the tensor fascia lata. So you need that much space. Sometimes the thigh is so short, you really can't even use a tourniquet for this. But this tourniquet has probably the smallest footprint in terms of area. S-mark bandage works fine, also keeps it fairly narrow. So we open the region, as I said, and make an anterior fasciotomy that is in line with the lateral release of the patella and continues on basically adjacent to the patellar tendon. So the patellar tendon is at this junction right here. Okay, you go right down to tibia at the level of the lateral border of patellar tendon. Then you open posteriorly. In order to open posteriorly, you can put your fingers on the inside to feel the intermuscular septum. So here are my fingers on the intermuscular septum, and I'm going posterior to that. So you go behind the septum, and you incise proximally and distally. And again, you get all the way down to Gerdy's tubercle. So it does narrow distally. You want the footprint distally to be as wide as possible. If you narrow this too much, you're not going to have room to make two strands of this. And we're going to want to turn this into two separate strands. Up here, you go up to the level of the muscle and you cut it back. In a larger femur, I will make two incisions, one kind of based at the greater trochanter and the other distally, and I'll tunnel between the two incisions. So once you've got this fascia, this is your donor ligament, and you split this, and then you take the posterior part and you twist it. So just like you would do for an ACL, you just twirl it, you twist it. The difference is it's not being twisted on the back table, it's being twisted anchored to Gerdy's tubercle. So I basically take a coker, put the coker on the end of the ligament, and keep twisting and twisting and twisting until it's really wrapped tight. I trim it down a bit, and then I run two separate fiber wires, one on each side, with Krakow stitches. So they're locking whip stitch all the way up. And when I'm done, I end up with two strands here. And this kind of keeps the most of the twist memorialized in the ligament. And then we're going to measure the diameter of this to see what diameter hole we're going to have to drill for the ACL. The other half is left untwisted. Now, sometimes you don't have such a wide footprint. In that case, take 2/3 of it for the back and 1/3 for the front. The front doesn't have to be that strong. It's extra articular. It remains flat. It's pretty strong in tension. The next step is something that I wasn't doing initially with the SUPERknee, and it is a notchplasty. And we've recognized that what's happened is we were doing the SUPERknee, and it was getting crushed by the lack of a notch. So it was getting crushed in here. And because of that, we started making a little medial parapatellar incision. Now, with this incision that we've got, we'll go back here. You can pull this flap over. You're already on the lateral border of the patella, so you can go a little bit further and expose the medial parapatellar region. And that's exactly what we're doing here, pulling it over, exposing the medial parapatellar region, okay? And once you do that, you can make a little arthrotomy there. Now, I stay out of the synovial area. I go over the fat pad, and I cut medial parapatellar, and then I actually cut out a little bit of the fat so I can see. I have to tell you, those of you, and I'm not an adept arthroscopist, but that's no excuse. Honestly, for the amount of notchplasty you need to do here, this takes 5-10 minutes. If you try to do this in a 2-year-old with an arthroscope, you would do an inadequate job. You'd never see, because this is one of the hardest things to see, is directly anterior posterior into the notch. And so right here, you'll make a little opening and you make your notchplasty. I use a circular gouge to cut it out. and an osteotome. And you basically remove it. You got to be careful of your direction, because if you don't mind the direction, you'll go into the growth plate. So you really remember that the condyles are separated posteriorly. And what you're trying to do is create a tunnel from front to back that joins the condyles in the back. So that's kind of what the notchplasty looks like. Most of these patients have a PCL, they don't have an ACL. So you just got to be careful on the medial side not to take down the PCL. Once you've done that, you can then put your guide wire in the epiphysis of the tibia. So this becomes an intraepiphyseal hole. And you can see there. So the guide wire is purely in the epiphysis. It starts medial parapatellar, ends up in the center of the knee, approximately halfway back. There are no tibial spines to guide you. Remember, these patients have no tibial spine. And then you've already sized the posterior portion, and you use an ACL reamer of that diameter to make a hole. So that's the big change for those of you who are already familiar with the notchplasty. I'm going to go back a few slides to show you something. So now when you look at this, I especially want you to look at this picture here. That's the growth plate. It goes all the way back here. So your cut has to be here. Okay? It has to enter the epiphysis and then not be as deep. If you keep going straight, you're going to get into the growth plate. So that's why it curves down. Okay? So you're trying to do this, and that's why you see bone in the back. That bone in the back is here. Okay? And so that's what the notchplasty looks like. And you're not going proximal. You're going really posterior. Okay, you're going from here kind of down this way. All right, and flexing the knee helps protect you from that to some extent, but just be mindful of this. You don't want to remove all of this posterior wall. Okay, you want it so that when you straighten out the knee, the front of the condyle, sorry, it keeps flipping. There. The front of the condyle doesn't pinch off the graft. And the graft's coming through here. So it doesn't get pinched off. Okay, come back to where we were. There's, again, a reminder of this notchplasty. You know, it's very, in a child, it's all beautiful cartilage. So it's really, you look at this and say, wow, I'm removing the knee joint, but you're really not. You're creating a notch. And this is very important, that you're intraepiphyseal. You are never, ever crossing or reaming out the growth plate. That's very important where you start this guide wire. Okay? Very important that the reamer doesn't ream out the apophysis. Okay, so we reached this point. Now, we need to go under the patellar tendon. So this is under the patellar tendon, we create a space. And this is for the medial part of the graft. So we then, you know, you can put a suture on the medial part of the graft and pull it through to the medial side. So it's going under the patellar tendon. And then it goes over the retinaculum. And you see here, here's the retinaculum. And so the next step is to go medially. And we need to get to the medial adductor magnus tubercle, AMT. So you're going for the adductor magnus tubercle here. And the medial collateral ligament attaches somewhere here, I think. And so you're opening along here. And the first muscle you will see will be the sartorius in the back. If you look carefully, you'll see the saphenous nerve. Don't damage that. Sometimes there's a little bit of a septum, a lot of times not. In the front is the quadriceps. And then right beneath that, a little distal and more on the posterior side, is the adductor magnus tendon. A lot of times it's muscle all the way to the end. Remember that congenital muscles are, they're muscular almost to the end. They have very short tendons. So you then develop a space under the retinaculum, but it's extrasynovial, under the retinaculum, extrasynovial, between the medial border of the patellar tendon and the incision for the adductor magnus. So once you create that, you pull your suture through by passing a loop of suture, a blind loop, catching your new suture and pulling it through. The next step is to go around the adductor magnus. I'm not sure it matters if you go underneath and over or over and underneath. It probably no importance. The key is that the adductor magnus acts as the fulcrum. So this is where you wrap the ligament around. The knee should be in flexion. You notice the knee is in flexion. Should be at 90 degrees of flexion. If you put the knee in extension, you will create a contracture. It won't be able to bend. So the knee should be in flexion. This ligament passes around this adductor magnus, and you suture it back to itself. I use fiber wire, suture it back to itself right here. Okay, so that becomes the first part. Leave this hanging outside. You'll see why. We're going to use that. Now let's come back to the lateral side. Lateral side, we have what I call ligamentized, that's the twirly, ligamentized fascia. And what we do is a figure 4 maneuver. This is called Grant's test. And in the figure 4 maneuver, you feel the lateral collateral ligament. And it tensions the lateral collateral ligament. You really can't feel the lateral collateral ligament in that position. You need to do a figure 4, and then you can easily feel it. You then, with the knee in that position, kind of mark or cut along the lateral collateral ligament. So you create a tunnel underneath it, and then you pull your ligament, your new ligament, underneath that. Now, this is part of the extra-articular ACL. This procedure was originally described by McIntosh, David McIntosh from Toronto. Actually, David McIntosh was one of my professors when I was a resident, and really a terrific man. I learned a lot from him. He's the guy who originally discovered the pivot shift test. And he was a very absent-minded guy, could never remember names. So I felt honored that he always remembered my name, but there was a reason. He always remembered because he'd call me anterior drawer. So he always remembered my name was Dror, and he got a kick out of that. He says, anterior drawer, come here, let me show you something. And, but I felt honored because he didn't know any other resident's name except mine. So I guess if there was a resident named Shift, he would have remembered him as Pivot Shift. But anyway, I learned this procedure from him, and he developed first it was called the lateral substitution, and that's this extra-articular part. And then he turned it into the lateral substitution over the top, which became one of the first intra-articular ACLs. So he would do the lateral substitution plus the intra-articular, and that was the lateral substitution over the top. So some people used to call it the Macintosh 1, Macintosh 2. So remember, we have sized this ligament already. We've chosen the ACL. As you've seen, we've already drilled it. And so now we make an incision into the periosteum in the supracondylar region. Okay? Now the intermuscular septum is here. We have not removed the intermuscular septum. So we cut above the intramuscular septum, and then we take a periosteal elevator and we go subperiosteally under the intramuscular septum, and then come out the periosteum here in the back, near the, so it's on the other side of gastrocs, heading for knee capsule. And then we put a blunt clamp, like a tonsil or a Kelly here, and we go under this and poke a hole in the back of the knee capsule with the knee bend. So now you have a hole from the supracondylar, or also known as the over-the-top region, all the way into the knee joint. Now, you can, in fact, you can see the, because we have the notchplasty, you can usually see your tonsil clamp coming through the back of the knee there. We now pass, this is called a Houston passer. There's many different type of snare-like passers. So it's a snare type passer. You go through this hole, you come out the capsule, you come into this subperiosteal tunnel, and then you feed it with the suture and pull the suture through. So this is going to be the over the top, the lateral substitution, and this is going to be the over the top intra-articular. So there it is. That is the extra-articular. Now, by the way, you can do just an extra-articular by coming back to itself. That's the original Macintosh. There are some indications for that when the instability is not that great and you don't want to go intra-articular. It's a much smaller procedure. And then here is going through the knee. Now, this slide shows you the rationale of this Macintosh procedure. So what Macintosh recognized is that by going under the lateral collateral ligament and over the top, this extra-articular portion is parallel to the ACL. So do you see how it's in the same direction as the ACL in knee flexion? Okay, so it helped eliminate the anterior drawer. It didn't get rid of the Lockman as much, because in extension, it's actually not, it's more, in extension, it's parallel to the lateral collateral ligament. So in knee flexion, you've got these, it's almost like the two bands, the anteromedial and posterolateral bands of the anterior cruciate ligament, and you're creating it in an extra-articular fashion. The second part of it is that because this extra-articular part loops from Gerdy's tubercle around the side of the knee cannot internally rotate. And you know, when the knee internally rotates, that's how you get the pivot shift. So it eliminates the pivot shift. Just the extra-articular eliminates the pivot shift because of this. In fact, you know, we talk about the ACL restricting internal rotation, and part of the mechanism of tearing the ACL is internal rotation, because it tensions the ACL. The opposite is true of the PCL. It restricts external rotation, and part of the mechanism is external rotation of the knee. Well, the ACL and PCL are basically located in the center of the knee. So they don't have that much ability to restrict rotation of the tibia on the femur. They're in the wrong location for that. These extra-articular ligaments are tremendously strong at restricting rotatory motion of the knee, much stronger than the natural ACL and PCL. So we're going to come back to that in a bit and talk about how important that is, because these knees for CFD have a global instability. They don't just have AP instability, they have rotatory instability. And so these external rotatory ligaments The one that goes on the other side to the adductor magnus, which we shall call either a reverse Macintosh or not. Macintosh did not describe it, but it's the opposite direction of the Macintosh, so I called it that. Plus, I wanted to honor David McIntosh, who was my professor. And the other name I give it, which is more for coding purposes, is an extra-articular PCL. So we'll come back and talk about that in a bit. So this is the extra-articular ACL. The other one is the extra-articular PCL. So, and think about it, when you've got a strap going one medial, one lateral, you have incredible rotatory control of the knee, better than any previous description of knee reconstruction. Okay, so now looking at it from the front, you can see the ligament coming out, but because of the notchplasty, it has a lot more room. Okay, and so now we fix it. So we are all the way through. So we go first to the lateral side. Now I extend the knee at this point. This is very important. This part here is not isometric, meaning that it is looser in flexion and tighter in extension. Now, yeah, we'd like to tension it in flexion, but then you'd never straighten out the knee. In fact, in the original Macintosh, you'd put the knee in 60 degrees of flexion when you tensioned it. And it would take the patient months to get the knee fully straight. We don't want to do that. Well, what's the purpose of having a ligament that's not tight? Oh, this ligament will become tight. We have something going in our favor. We have growth. So look where this ligament is anchored, above the growth plate. So I'm not worried that it's not tensioned. It's auto-tensioning. This thing tensions all the time. As the child grows, it auto-tensions. Kind of a cool feature of this ligament. So we're okay with that. Put it in extension so you don't over tighten it. And then we make a drill hole with, I usually use a 1.8 wire, front to back through the femur. And then I pass a suture. Now I usually use a non-absorbable suture here. Why? I'm sorry, absorbable suture. I use an absorbable suture. A lot of times later, we're coming to put an external fixator here. And you're going to forget about this. It's invisible. If you have a non-absorbable suture, it'll get infected from your pins, and you'll wonder why you have a festering sinus coming from there. And eventually you'll explore it, as I have, and you'll find this suture you forgot about. So I use absorbable suture here on the bone. Okay, next you're going to pass that underneath this Macintosh portion, or the lateral substitution portion, the extra-articular, and you're going to tie it. And that prevents this from dropping down. So, you know, Macintosh relied on the intramuscular septum to prevent the sagging. I think, first of all, he was doing adults where it's much stronger. And secondly, I have found that it stretches. So I prefer to anchor it to bone here and prevent that sagging. So I do that. Then you retension again, and this time you put in a guide wire into your tunnel over here, and you put in a biotin adhesive screw. So biotin adhesive screw, I mean, you put a metallic one. We use the absorbable one. I think they work the same. The absorbable one never absorbs. You can find it there 10 years later. So I think it's all a hoax. Whatever one you want to use is fine. The only advantage of the absorbable, you don't see it on the x-ray. The metal one is always there on the x-ray. So we put that and we lock it in place. I usually put it above the ligament, so the ligament is below. So that anchors my intra-articular ACL, and of course, also the extra-articular. So we're finished that portion, and now we're ready to come back to the reverse Macintosh part. So again, I want you to notice something. When you look from the side, this is in the same direction as the ACL. So by the way, as soon as you repair this, which by the way is repaired in flexion, so this is the opposite of the other side. This one needs to be repaired in flexion. When you repair this, this one becomes looser in, this one becomes looser in extension, that's it, and tighter in flexion. So when you look at the direction, it's the same direction as the ACL. So, but a minute ago I said this is the extra-articular PCL. So this ligament, this single ligament, is both an ACL and a PCL. Let me explain. For the direction, it's an ACL. So when you do an anterior drawer after this, it eliminates it. It's really tight. And because you tightened it in flexion, remember that the Macintosh you tightened in extension. So it's a little bit loose in flexion. This one is tight in flexion, so it completely eliminates the anterior drawer. So why is it a PCL? Because it wraps around the knee in this direction. And so it prevents external rotation of the tibia on the femur. So external rotation of the tibia on the femur is prevented by the PCL. So it has a PCL-like property by preventing that external rotation. Now, why else is this one important? Why can't we just rely on the lateral one? Well, so this is the first ligament reconstruction I invented. This was in 1994. And this one, when we go to talk about the dislocation of the patella, it'll be clear that this one is actually an extra, it prevents that rotatory subluxation of the tibia on the femur. So in most dislocations that occur during lengthening, they have external rotatory subluxation. Why? First of all, a lot of people don't lengthen the iliotibial band, and the biceps gets tight. Those two structures cause that external rotation subluxation. So tibia rotates externally and drags the patella with it, and they dislocate. By creating this ligament, you make it very difficult, almost impossible, for the tibia to ever rotate externally. Although the knee can still get a flexion contracture, it won't get it with the rotation. It'll get it just as a flexion contracture, which doesn't promote patellar malalignment or dislocation. Anyway, that is the rationale. Can you guys just give me 1 second to deal with something? So going forward, we now take the reverse Macintosh and we go outside the retinaculum and we come out to the front. So remember that this ligament or this fascia went under the retinaculum, around the adductor magnus, and now comes outside the retinaculum. And then you suture it to where the intra-articular comes out of the bone. So if you remember, the intra-articular comes out right here. So you're going to loop this under the skin back to this. So comes through and then gets sutured to there. this is what I call belt and suspenders. In other words, this is giving you double the reinforcement. The biotinadesa screw, what if it slips? What if it pulls out? You know, it's soft bone in young children. Well, by suturing it this way, it can't pull through. What if this thing, you know, becomes loose? It's double anchored. It's anchored at the top and it's anchored at the bottom. So this is really strong. This is so strong that even in a 2 or 3-year-old, you can do this repair and move the knee right away. You never have to worry that this is going to loosen. So we do this procedure. We don't use a cast. We start them moving right away, and we splint them in extension to prevent a flexion contracture, but they go to daily physical therapy, and the therapist is allowed to work from 0 to 90. We don't go past 90 because we're worried that the ligaments aren't that isometric and therefore might get stretched out beyond 90. But 0 to 90, there's no issue at all. So then we cut off the excess of the 2 ligaments. We close the capsule where we made the little small arthrotomy. I mean, that arthrotomy is 2 to 3 centimeters long. It's not very big. And it's not really through synovium. It's not parapatellar. So you notice it's not parapatellar. It is right over the fat pad. And that's why we're not cutting through muscle. We're not causing knee pain from this. We don't get knee stiffness from this. And then we're done. We put in a drain and on the lateral side, and then we close. All right. So that's if the patella tracks normally. That's the original SUPERknee procedure, okay, from 1994. Now, patellar maltracking. And just, by the way, just one last comment on this. So I told you that SUPERknee is a conglomerate. It's not one procedure. So let's look at how many procedures this is. In this case, it's an extra-articular PCL, which is that reverse Macintosh, okay? It's an extra-articular ACL, which is the Macintosh. It is an intra-articular ACL, which is, you know, the Macintosh 2, and all subsequent knee procedures, you know, include that tunnel. But this is an epiphyseal sparing type. You will see epiphyseal sparing information out there. I think Min Coker from Boston has popularized that. In all due respect for Min, who's a good friend of mine, I described that going back to, I think first publication was 1998, long before anyone else did, to my knowledge, of the intraepiphyseal. I get no credit for it, nor do I really care that much, but I'm just kind of mentioning it to you. The sports medicine guys were not the first to talk about epiphyseal sparing ACL ligament reconstruction. Us limb reconstruction guys were. So something we can take pride in. So it's those 3 procedures. Oh, and it's also notchplasty now. So it's those 3 procedures that make up 3 separate procedures, and then with the notchplasty 4, that make up the SUPERknee, right? That's why the SUPERknee is not one procedure, okay? Now we're gonna make it a little bit more complicated, because in addition to everything we just talked about, we have a maltracking patella. And so the patella is a little maltracking, and especially when you flex the knee. Part of it is the tether of the iliotibial band. So just the lateral release that we're doing will help. But a lot of times you need to move its patellar tendon medially. Well, how do you do that in a child? So We use a procedure I learned from a French surgeon called Gramont. He published it actually in German first. And so you do this lateral release that we talked about before, but then you extend it and you extend it down along the lateral side of the patellar tendon, along the medial side of the patellar tendon, and onto the apophysis. So you extend on the apophysis. So you're going into the tibia. This is already the growth plate here. And so here's the extension, you see? And essentially, this is a pediatric Elmsley triad. And what you do is, because the periosteum is so thick, you release all the Sharpie's fibers from the patellar tendon insertion, which inserts into the cartilage. You release those Sharpie's fibers and take as little of the cartilage as possible, almost none. And you essentially strip the patellar tendon, keeping a wide base onto the apophysis. Okay, so here you can see the cartilage, which is indicated in blue, and you release it along there. You actually get past the apophysis to the point that you strip it with a periosteal elevator onto bone. So you are crossing the growth plate area. Despite that, I've never ever had, you know, I've never had a growth arrest from that. So just 1 second again, please. 1 second. Sorry, my throat's getting dry, and my wife sent me up something to wet my throat with. Okay, so coming back to this, we are doing essentially a pediatric version of Elmsley triad called the Gramont. Gramont was a French surgeon. He has passed away. He was from Lyon, France, L-Y-O-N, Lyon, France. Lyon is famous because it's the first place to ever start with cinema. The very first movies came from Lyon. Okay, the Lumiere brothers. Okay, now we then can shift the patellar tendon. So you see this big V created? I want you to look previously. So before that, this was adjacent here and we cut it. We want to shift this to the dotted or the dashed area, okay? So once we release that, our pivot point is way down here, and then we imbricate it on the medial side. So we've created a shift of the tuberosity, okay? We then pass the reverse McIntosh, do the medial incision, wrap around the adductor magnus, go under the lateral collateral ligament, create the fulcrum over the intramuscular septum under the periosteum, make our intra-articular hole with the notchplasty and all of that, anchor it, etc. So all the rest is the same. But we start with the patellar realignment, the lateral release, the Gramont procedure. We're done this, we anchor it. Now we're back where we left earlier, okay? So now what's the super knee? Reverse McIntosh, McIntosh, intra-articular ACL, notchplasty, and Gramont procedure, okay? So we build on it. So it's not, that's why I say it's not one procedure, it's multiple. Okay. Langenschuld. So the next step is the patella is dislocated. And I'll tell you a story. It's a fun story. In 1994 is when I developed the super knee. And the first super knee I did was in order to solve this problem. I had a patient that I had lengthened that even though I had fixation to the tibia, after I removed the frame, the tibia got a flexion deformity, externally rotated, and the patella dislocated, okay? Despite even articulating across the knee. It still happened, okay? So after that happened, I told the parents, this was 1993, I told the parents, we gotta do some kind of procedure to get the patella back. And the parents were very religious Christians. And so we scheduled the child for surgery. And then just the day before the surgery, they canceled the surgery. And, I called them up and said, you canceled your surgery. This is emergent. This is really urgent to treat this. And they said, we understand, doctor, and we greatly respect you, but we went to our church and God told us not to do the operation right now. We're going to do it, but he said, God told us this is the wrong time to do the surgery. Okay, well, I yielded to the higher authority, obviously. And so then we rescheduled the surgery for January. And, but once again, God intervened and surgery got canceled because they called me and said, sorry, doctor, God told us again, this is the wrong time. So I ran into the mother actually, she was the secretary of one of my doctor friends, and I ran into her at this doctor's wedding, and I said, listen, I don't mean any disrespect, but this is really bad for your daughter's knee and we need to do something. And she says, no, we're going to do it. And I'm pretty sure that God will allow us to do this on the next time. So the next time was April 1994. So we'd started in November, now we're 6 months later. And I schedule her for surgery. And fortunately, God said that we could do this. It was okay. And the night before the surgery, I was in my office, my home office, and I was cleaning up and going through these articles that I had photocopied and putting them into file folders. And as would always happen when I did that, I'd see some article and I'd sit down and read the article. I didn't get much filing done. And that's what happened that day. I ran into a 1992 article that I had photocopied of Dr. Langenschuld. Okay, this is the famous Langenschuld, famous for Blount's disease. But he had published an article in JPO 1992 on congenital dislocation of the patella. And I read that article and the light bulb went on. And now I knew what I needed to do for this girl. So I don't know if we would, I guess you can call that divine intervention. It's a true story. I probably would not have read that article at the previous 2 scheduled surgery dates, but on that date that we were allowed to proceed, I read that article. So call it what you want. And the Langenschuld procedure really is a brilliant operation on how to reduce the dislocated patella. And it was a new concept. And I'm going to show you that. Now, look, like any good orthopedic surgeon, and the definition of orthopedic surgeon is someone who modifies an operation the first time he does it. I modified the operation, but there's only small modifications that I made, and you'll see why. Now, I also recognized I had this rotatory subluxation, and I was looking to think, how can I stabilize this rotatory subluxation? And in Langenskold's article, he talks about this rotatory subluxation, but he offers nothing to fix it. Part of his operation is to lengthen the iliotibial band. So I thought, wow, how could I use the iliotibial band to create some kind of ligament that can internally rotate? And it was in April 1994 that the reverse Macintosh idea came to me. And I think, and I credit it to Macintosh because I grew up with the Macintosh and the idea of an extra-articular ligament. So when I was thinking of how to create a extra-articular force that would prevent external rotatory subluxation, I knew that he had his ligament that prevented internal rotatory rotation. So couldn't we do the reverse? Well, that would make sense. You just go in the opposite direction. And that's where the reverse Macintosh was born. Okay. So two things came out of this divine intervention. One is the reverse Macintosh, and this, which in my first publication on this, and you can, it's in a book called The Child with a Limb Deficiency, published 1998, written 1997. I called it the Paley knee reconstruction. The name SUPERknee didn't exist yet, and you know, since then I call everything the SUPERknee, and its components are now I refer to as the reverse Macintosh. So this was born in 1994. Again, lateral exposure, lateral incision, harvest the fascia, and Langenskold only lengthens the IT band. We get the same effect by harvesting it. And we take as much of it as possible and reflect it distally. Now, the other external rotatory structure is the biceps. So we're going to lengthen the biceps, and Langenskold's procedure includes a Z lengthening of the biceps. What he doesn't do is decompress the peroneal nerve, but that's kind of a component of mine, that if there's a flexion deformity of the knee, not if there's not, but if there's a flexion deformity of the knee, I won't do an acute correction where I'm internally rotating the tibia and extending it without first decompressing the nerve. So I proceed to reflect the skin flap back with the knee flex and decompress the nerve. So I open the nerve, the common peroneal nerve proximally, separating it from the biceps muscle and tendon. Then I make a transverse fasciotomy of the anterior and lateral compartments. And then I can see the first tunnel. I reflect back the muscle of the peroneal muscles, lateral compartment, and I cut the band of tissue that is overlying the common peroneal nerve. You can see it dividing into deep and superficial. And I cut that band, and that's the first tunnel. And then we've published and recognized a second tunnel, which is an intermuscular septum between the anterior and lateral compartments. And we cut that as well. Okay, so the first and second tunnels are now decompressed. So the second tunnel is just the deep peroneal nerve. All right, so that's an important part, especially if you have a flexion deformity. Now we make whatever your favorite type of Z lengthening, not a fractional lengthening, a Z lengthening of the biceps. I actually take a little central flap, so it's not a Z, and then cut the rest of it. It's my own way of doing it. And it's especially good because you don't have a lot of tendon in congenital muscles. So this makes sure I get the tendinous portion, which is in the middle. Here's the short head, here's the long head, and this is kind of in the middle of the two. So it's a long flap, and then I take all of the rest of it as the other part, okay? That's essential. You need to do that. That untethers the tibia and allows it to rotate internally. You now incise the lateral border of the patellar tendon, and of course, the lateral capsule. Do not cut the synovium. So you go all the way, just like we did before, and medial side as well, except you go, this time you do cut the vastus medialis obliquus and part of the vastus medialis. Okay, so you raise a flap of vastus medialis. This is all capsule, retinaculum, all the way down to the apophysis. At the joint line, I make a transverse cut on the capsule, transverse cut, and lift a flap of capsule here with the vastus medialis. I leave behind the synovium. So this is all synovium. And you create a tunnel between the synovium and the capsule retinaculum. Now that tunnel, there's often fat there and so on, gets thin in some areas. You go all the way to the medial gutter. So you're coming all the way to the medial side of the knee joint. Okay, remember this is way on the lateral side. It's dislocated. So to give you a cross-sectional view, you're cutting the capsule, or undermining the capsule from the synovium all the way to the medial gutter. Laterally, it's a short distance, you're doing the same. So now you have an intact synovium, and you're about to cut the synovium both laterally and medially along the patella. You're going to create a hole in the patella, hole in the synovium where the patella was. Before you do that, elevate the quadriceps muscle in the suprapatellar pouch between the synovium and the muscle. This is where there's a lot of thick tissue anteriorly, but quite thin posteriorly. And easy to get lost there. You do the same between the fat pad and synovium and the patellar tendon. So anteriorly here, you leave the synovium behind even where it overlies the fat pad. And you do the Grammont, as I said, cutting the Sharpie's fibers and elevating the patellar tendon off of the apophysis up to the periosteum. You see bone, cartilage, and you strip that a little bit. Finally, after you've done all of the separation of capsule, muscle, tendon from synovium, then and only then do you open around the patella. And now you cut the synovium. And you can see here opening the synovium and leaving behind a hole on the lateral side of the femoral condyle. This is the lateral side. This is anterior here. Lateral side of the femoral condyle, which is exactly the size of the articular portion of the synovium. So you've got the quadriceps, the patella, and the patellar tendon, all as a unit, completely mobile. Well, they're mobile because you also mobilize the muscle here. You do a bit of a quadriceps plasty, elevating the vastus lateralis off of the intermuscular septum and synovium and periosteum. So it's extra periosteal, always. You then close this. Now, by the way, before you close, if you were doing an intra-articular ACL, I'd do it through this hole. This is mobile enough that you can see into the knee joint and do your notchplasty. All right. So, but you can close this, and you close it longitudinally. Now, by closing it longitudinally, it doesn't tighten it. It doesn't tighten it proximal to distal. It tightens it medial to lateral. So it takes some of the slack out of the synovium. The synovium's too loose because it dislocated. So now you're closing that. And this is done with an absorbable suture. So now your tibia is free to rotate. Why is it free to rotate? Because the three structures that tethered it, what were those three structures? They were the iliotibial band, that's been lengthened, the biceps tendon, that's been lengthened, and the patellar tendon, and that's been detached. Now, the original Langenskjold truly detaches. It actually removes the patellar tendon here and reattaches it. So you asked me what were my modifications of the Langenskjold. Langenskjold made it easier. He would detach this, lift it up, and then it was very easy to detach the patella from the underlying synovium. I'm having to work around an intact quadriceps patellar tendon unit. So I don't completely detach it ever. Now, you can now move it medially, both because you rotate the tibia internally and because the quadriceps is free. If the quadriceps is not free enough, keep going up with the liberation of the quads. And essentially that's like a Jude quadriceps plasty. And that becomes, so quadriceps plasty to a lesser or greater extent is part of this Langenskjold procedure. Again, that's kind of part of what I do. I don't think it was in the original Langenskjold. Now, when you can move the patella to the center, you now mark its lateral and medial borders when it sits on the center. It's very important to do this with the knee in extension. Never do this with the knee in flexion. If you do it with the knee in flexion, you'll end up with patella baja because your hole will be more distal. So this should be with the knee in extension. After you've opened this, so you can see there's your opening in the patella, then you know, I gave you guys a misleading thing. I said about if I do a notchplasty, I forgot. It wasn't through the lateral synovial hole, it's through this one. So when you make your new hole, you're right over the notch. It's very easy to do a notchplasty. Sorry, so it's through this if you do need to do a notchplasty and an ACL. So one of the things is, because the patella's been out there, the suprapatellar pouch has been obliterated. So there are all these adhesions up here. In congenital cases, they never existed. If this is after lengthening, then it's true adhesions have developed. So you have to kind of release these adhesions all the way medial and lateral. Okay, so you keep the synovium intact. This probably generates a little bit of bleeding, but it's under tourniquet. You do need to release that. You're now ready to do the Langenskjold repair. So now what you repair is you reimplant the patella into a new synovial hole. We start at the top and we anchor it to the superior pole of the patella. In young children, the patella is cartilaginous, so you can just push a needle right through it. If not, you can go through the muscle bone junction if it's an older child. So you come through the front and then you come back to itself. okay? And you tie your first knot at that level, and then you keep sewing. I like to sew the lateral side first, so I keep coming around like this, sewing the edge. So you can see from here all the way here. And then you're going to get to the inferior pole, and you're going to go through the patellar tendon at the inferior pole, you see? And then up the medial side. And finally, you're going to suture under the muscle here and come through the muscle and then back to itself, and the knot is actually underneath. So this becomes my new patellar reconstruction. Now we take the muscle, the vastus medialis, which has the retinaculum, the capsule, attached to it. First of all, it's very loose. Remember, this used to reach all the way to there where the patella was. So it reaches easily to the lateral border of the patella. And I usually suture it to the lateral border of the patella. You have to be careful with this. If you over tighten, you can actually create a medial dislocation. It's happened to me. So you got to be careful. And sometimes I'll just put a couple sutures, test the knee in flexion and extension. And if it's too tight, I'll back off and go to the middle of the patella. Oh, by the way, before you do that, test your movement of the knee. So this should move, and it's amazing how just the synovium is enough to hold the patella in place without any capsule. Just this is enough to hold it in place. Now, what you might find is, and you could have determined this at this stage. So when you reduce this, one of the things I do is I put my thumb on the lateral patella and I flex the knee. If I cannot flex the knee without the knee dislocating, then the quads is too tight. There's only two solutions to the quads being too tight, because basically the quads is short. So one solution is to do a longer quadriceps plasty up the femur, freeing the quads up. You could do it all the way up to the greater trochanter, and you could even cut the rectus femoris tendon. And that's one way to gain quadriceps length. So it's the original Jude quadriceps plasty. The other way to do it, and especially if there's a flexion contracture of the knee, and I'll show you guys this in a case shortly. The other way to do it is with a shortening of the femur. So by shortening the femur, you gain length of the quadriceps, but you also gain length of the hamstrings, and you also gain length, most importantly, of the neurovascular bundle. So when you're correcting a flexion contracture, I will do a little bit of quadriceps plasty, but mostly I'll shorten 1 or 2 centimeters of the femur in order to gain that length. Now we advance that, as I said, and we now medialize and repair the patellar tendon to make sure that it is tracking centrally. So that's your Grammont repair. So I combine the Grammont with the Langenschuld. All right, so already it's 2 different procedures combined together. Now we pass the, well, remember, this had an external rotatory subluxation of the tibia on the femur. So we want to prevent that. So we pass this anterior portion of the iliotibial band, and we pass it under the patellar tendon after it's been sutured. In the Langenschuld, I don't make a separate incision because I've got enough exposure here to get to the medial side. And I get to the adductor magnus, okay, and I go around it. And so I go under the retinaculum, around the, what do you call it, the adductor magnus, and back over itself. Okay, so I've sutured it to itself. So this is the reverse Macintosh. This is really important because this tibia already demonstrated this external rotatory instability once. So you are locking it and preventing it from rotating externally. So this was my original, what you're seeing here was the original SUPERknee that I did, which involved the Langenschuld, the Grammont, the newly invented reverse Macintosh, and I combined all those two together, all those three together, and that was the first SUPERknee in 1994. You can then suture it back to itself. Now, if you want to combine this with the intra and extra-articular ACL, the Macintosh, you can do that. That's not illustrated right here. What you can see here is repairing the biceps tendon at the end, and then the skin. So you could do all of them. You could do the intra and extra-articular ACL, the reverse Macintosh, which is the extra-articular PCL. You can do the Langenschuld, the Grammont, notchplasty, all in one procedure. So that's why I say there's all, it's like you have a menu and you're choosing from that menu what you need. This is a great example. This is a child with CFD. You can see short femur. She has a little bit of a dysplastic hip, but more importantly, she has this valgus knee. And what it is, it's a rotatory subluxation of the tibia on the femur with a dislocated patella. And it's also anteriorly subluxed. The usual retroversion of the femur. This is in surgery, and you can see the catch of the knee. The knee. Okay, so it's called the drop test. In other words, I'll run this again. Sorry, it's kind of noisy, but watch it just hold on its own. So it's got a catch. I let go of it. There's the knee holding on its own. So it'll have this thick, thick band. So that iliotibial band is not normal. It's very thick. And sometimes it's so thick it causes this rotatory subluxation of the tibia on the femur. This is without lengthening. This is just congenitally. And in addition, of course, so there's, I made an incision up here to do a iliac osteotomy to cover the femoral head. I made the incision down here for the SUPERknee. I tunneled between the two incisions, harvesting the fascia, lata, and iliotibial bands. This is showing you this tunneling procedure. And then this is passing the lateral portion of this under the lateral collateral ligament, about to go over the top. This is the medial portion of it. I guess this one did not have a dislocated patella. And then this is coming around the medial side, around the adductor magnus back to itself. You can see here the pulling it all the way to the medial side. And when I'm done, there's you can see the shadow of the interarticular hole for the interarticular ACL. So there's an extraarticular ACL, extraarticular PCL, intraarticular ACL, all of that. And we did the iliac osteotomy, as I showed you last week. And the only thing I didn't correct here is the retroversion, which now we might do that too. And this is what it looks like. No more of that valgus like you saw before, no more rotatory subluxation of the tibia. And we lengthened the femur with an external fixator articulated to the tibia. This is many years ago, early 2000s. And then this is before. I want you to see, look how dislocated it was. This is after the lengthening with the rotting of the femur. Here she is at a later date. You can see knees nicely reduced. Look how straight her knee is. And here's as she's grown even further. That's her knee range of motion. And this is her walking. So now she's much closer to equal leg length. She's had the femur lengthened. She's had the SUPERknee procedure. And that's what we're able to achieve. This is an almost 14-year-old boy, has a fixed flexion deformity 25 degrees, has a quadriceps lag of 40 degrees, lateral patellar dislocation, short femur, and you can see this is his flexion deformity of the knee. And that's what he looks like. He looks just like the other girl with that rotatory subluxation. And I think he has some knee valgus. And anyway, you can see here a AP of the tibia with a rotated view of the femur. And you can see here a lateral of the tibia with a lateral of the femur with a oblique of the tibia. So in no position does this tibia line up to his femur in a rotational. So here is in surgery, and you can see he rotates externally a lot, no internal rotation at all. This is his maximum knee extension. So this is a congenital dislocation of the patella with a little bit of CFD. And this is what we did. So we ended up having to shorten his femur a couple centimeters. He had a little bit of varus of the femur, so we put a hemiepiphyseal, it was a staple. This was before 8 plates. And you can see we had to realign his tibia even with this plate here. But here's his flexion and extension when we're done, and we relocated the patella. And I think the key is the relocation of the patella. So here's so we did the whole SUPERknee procedure as we talked about, but with shortening. Here's his knee flexion, here's his knee extension. So this is just going one step further and adding a little bit of flexion, shortening of the femur in order to allow treatment of the flexion deformity. In some cases, you might have to do a posterior capsulotomy of the knee. He didn't require it. This is his walking this is a few years later. And you can see, I mean, his knee just tracks perfectly normally. Remember, it's the left knee. And you can see he's walking normally. He's bending his knee normally. We can actually, I think on this video, I'll just move it faster. We'll see him from the side. And look at and there's his ability to run. Knee never buckles. He has full knee extension. He has no extensor lag, no flexion deformity. And, you know, he requires a little bit of lengthening of the femur in the future. But that's what can be achieved. Natsuo Yasui, a good friend of mine from Japan, previously Osaka, now Tokushima, Japan, he invited me over there to treat such a boy who had this bilaterally. So you can see this boy has it on both knees. And you can see exactly the same pathology, the patella dislocated, the rotatory subluxation of tibia and fibula. Look at the femur. I mean, it's beautifully demonstrated here because this boy's older. You can see the patella on the side. There's on the CT scan. So I did one of the legs and they learned it from that surgery and then they did the other side. But we had to shorten the femur. This is how he walked before surgery. And this is how he walks now. Well, this is quite a few years ago. I'm sure he's a young man by now. This was also done in then, I think, either late 90s or early 2000s. I showed you this case the other day, and we focused on the hip, but this is a 24-year-old woman. And my point of showing this is that this is doable in adults. In fact, I should have put on this one lady who was 59, the oldest patient I've done this operation on. I did it when she's 59. She's now 79. She is, and I did this on a 59-year-old woman. The reconstruction has lasted 20 years and she has not had a knee replacement. But here's a 24-year-old woman, and you can see the dislocated patella, the rotatory subluxation. It is a CFD and fibular hemimelia, complete absence of the fibula. That's what she looked like before. She had a terrible prosthetic with no knee bend in equinus. We talked about the hip, but it's the knee I want to focus right now. So when I finish, she's got complete realignment of the tibia on the femur with this procedure, okay? And that's what she looks like. And we talked about her hip, but more importantly, I want to show you her knee. So she went through a lengthening, femur and tibia, and we looked at this, but look at her knee. And you can see her knee function here, full extension, full flexion. She doesn't have any lag at all.
Now bring your knee up to your chest.
And she has full knee
keep
flexion.
Walking down that way. Right now.
So just my point here is you can do this in adults. You can't just do it in children, you can do it in adults. Okay, a couple more elements in the super knee. We're still building. You probably thought we were done. Hopefully we still have a few minutes. So posterior capsulotomy. This is kind of the next element. And so again, lateral exposure, just for a posterior capsulotomy, you don't need this much exposure, but this is with harvesting already of the fascia, as you can see here. You palpate the perineal nerve, and then I already showed you the perineal nerve decompression. So anytime you do a flexion contracture of the knee, the very first step to find and decompress and protect the perineal nerve. Anterior and lateral compartment transverse fasciotomy. First tunnel, second tunnel. Okay, first tunnel is common, second tunnel is deep perineal nerve. Okay, and now you can safely lengthen the biceps. Okay, the next muscle is and I'm showing the knee from behind. We don't see it this way. So this is really more illustrative. But what we're going to do, we're going to take down the medial head of gastrocnemius, lateral head of gastrocnemius. We're going to start our capsulotomy going across. We're going to get to the other head of gastrocnemius, the medial, and we're going to cut it. And then we're going to complete our capsulotomy. That's what we do. We do it all from a lateral approach. So here's the medial head of gastrocs. Take it down. There's fat back here. We stay in that interval between capsule and the fat. And we keep working that interval. The only vessel you should see if you're behind the femur, not behind the tibia, behind the femur, behind the femoral condyles, is the central geniculate, which kind of goes to the PCL. You can clip or cauterize that. Then you make a capsular opening and you work your way across the femoral condyles. Now I'm going to take a step backwards and emphasize something. So you can see here I'm behind the distal femur. Never want to be down here. Why? Because if you go down here by accident, you're going to run into the anterior tibial artery and vein. It's happened to me. I've cut it one time. I thought it was the central geniculate, the biggest central geniculate I've ever seen, but big mistake. So you don't want to be back there. You don't want to be at the, what do you call it, back of the tibia. You want to be on the back of the femur. You'll never see the anterior tibial vessels. Okay, here's the medial head of gastrocnemius. Where's the femoral artery or popliteal artery and vein? They're back here. You don't actually need to see them. I know this is not comfortable for a lot of people, but anyway, I do this all from lateral side. Dr. Feldman, my partner, likes to make a separate medial incision. I don't find it necessary. I can do it all from lateral side. Anyway, I come across there. I cut the rest of the capsule here, and that completes the release. Okay, so that is the entire SUPERknee capsular release. Okay, so the capsular release, again, is part of the SUPERknee procedure. And at this point, you can proceed with, before I show you, you can proceed with whatever you want. You can proceed with Langenschuld if you needed that. You can proceed with the ACL, PCL, all that reconstruction. But this is again, one more element is the posterior capsulotomy. And you can see it's the same utilitarian lateral incision. We have not changed our incision, and we've done everything. We've got, from this incision, we've gotten all the way from the medial to the lateral side, I'm sorry, from the lateral to the medial side, to the anterior, to the posterior, whatever we needed. Do you notice when you suddenly extend the knee, sometimes the tibia is posteriorly subluxed on the femur? So what I do in those cases, I make a small capsular hole, stick a Homan elevator there, and very slowly extend the Homan down to pull this forward. And it does pull it forward. Sometimes what's holding you is either the PCL itself or some connections to the PCL. In the very extreme case, you sometimes have to cut the PCL, which is very unpleasant to do. Like in arthrogrypotics, if you don't cut it, it'll break off because there's so, so there are certain cases that you just have to do that, sometimes in a, usually not in a congenital pterygium. In these CFD, never, but you do need to pry it forward sometimes. Now, you have two ways to treat the flexion contracture of the knee afterwards. You can either splint them and try to splint them in some type of cast or brace and start physical therapy right away. The problem with CFD in particular is the femur is so short, no cast or brace can hold it in extension, and you get a recurrence of the knee flexion. So a lot of the times I want to temporarily arthrodese the knee. So that's a procedure. That's the code also, is temporary arthrodesis of knee. And what we will do is we will pin the knee. There are many ways to pin the knee. The one I like the most lately is either straight across the ankle, or to avoid the ankle, coming up the medial malleolus and having the wires bounce off the lateral cortex and head up here. These are 1.8 millimeter wires. And I basically tap them up. I don't actually drill them up. I tap them up to here and then drill across the knee. And the two wires come through, two 1.8 wires. There's an advantage to using 1.8 wires. So sometimes, not often, but sometimes, you might get, when you take the tourniquet down, some circulatory embarrassment of holding the knee in such rigid flexion. Well, the beauty is it's not rigid. You can take your hand and bend the knee, and the wires will slightly bend, and you allow 5 or 10 degrees of knee flexion. So as an emergency procedure, the 1.8 wires are stiff enough to hold the knee on its own, but flexible enough to allow you to force them into a little bit of bending. So I leave those in for 6 weeks and then take them out. I bury them at the medial malleolus. We then repair the biceps. Now, if we needed to do knee ligaments, we would do the knee ligaments before temporally arthrodesing the knee. Okay. Now, one other aspect of this, we didn't talk about shortening the femur here, and I may switch to another PowerPoint to show you the shortening aspect. in a procedure called the rescue knee. I forgot to kind of load it here. So let's finish this last part and then we'll go to the rescue knee procedure. So the next component, again, we're building. There's so many components to the super knee, is the PCL reconstruction. And I'm not talking about the extra-articular PCL, I'm talking about intra-articular PCL. So intra-articular PCL, we can also do through this incision, but if you were doing it alone, I would just make an incision up to here. You don't need such a big incision. So when you're back here, it's very easy to get to the back of the tibia. I told you to be careful of the anterior tibial artery, which is a little bit lower. Remember, anterior tibial enters between the fibula and the tibia, it enters right here. And so it's going to be about there. But you can just, you know, where the capsule attaches to the back of the tibia, you can expose that and just be careful of the vessels. If there are any there, you usually don't see any. And you expose that. And, oh, 1 second, I have to plug in my computer. Okay. So then you drill a wire in the epiphysis, so it's again epiphyseal sparing. You put this into the epiphysis. You're basically going right from medial to Gerdy's tubercle to the center of the knee in the back. Okay, so medial parapatella, kind of between the lateral border of the patella and Gerdy's tubercle, right there. And you're going to end up in the center of the knee. You size the ligament, and then you use an ACL of the appropriate size. And by the way, I put a Cobb elevator here for my wire. I don't know if I showed it here. Yeah, when I put my wire in, I have a Cobb elevator, so I don't just keep going and puncture something. So I hit metal. And then I ream with my ACL, also with the Cobb elevator protecting me. Now I pass my Houston passer, and I pull this through. So now I've got from front to back a ligament. Now I go to the medial side. And on the medial side, I either make a separate incision, or if I already have the flap over, I'll go there. And I go from anteromedial. So it's kind of there. So it's midline, a little more anterior than where the adductor magnus was. And it's distal also. So you're in the epiphysis, and then I aim for the notch in the back. Now remember, for the PCL, there's no notch issue because the PCL enters between the condyles. Condyles are open in the back. So when I make a little incision medially, come through there, and I want to see it coming out. So I can see it coming out there. And then I make sure I'm I'm distal to the growth plate. And then I ream a hole across. And then once I've reamed, I pull this through and anchor it there. And that's my PCL. And sometimes I'm doing this with a capsulotomy open. It's even easier. So I come through there, and then I tension it on the lateral side with the knee inflection, okay? And I put the biotin-adhesive screw in. I also keep the extra part of the ligament and bring it out the medial side and pull it through next to the patellar tendon. And then I just suture it down. So that is remember, that was the reverse Macintosh. So my total ligament coming from the front, through the epiphysis, out the back of the knee, crossing the back of the knee, going between the femoral condyles, coming, exiting on the medial side, and then using that as the reverse Macintosh. Incredibly stable. Can you imagine this now? And then imagine the other part that if we had both halves of the ligament coming under the lateral collateral ligament, over the top, through the knee, exiting here. So we could have intra-articular ACL and intra-articular PCL in the same patient, and extra-articular ACL and extra-articular PCL in the same patient, 4 ligaments. Incredibly stable. There's so many cases I've done that on, and in adults I do that. So there's a lot you can do with this, not just for congenital cases. So that is up to now the portion of the SUPERknee. And I'm going to stop for 1 second and add one more thing, if you don't mind. Do we have time for me to add one more thing?
We have time, we have time, sir. We have time.
Okay, so let me just open rescue knee, because I should have loaded that too today. So rescue knee, and I'll share my screen again.
Manish sir?
Yes.
Yes.
I'm sorry, go ahead.
Dr. Shamshul?
Yes, sir, you can go ahead, sir.
Yes, you can go ahead, sir.
Okay, thank you. So I am going to share my screen here. Can you see this? Rescue knee? Okay, I assume that's a yes. So the rescue knee is what I really did the first SUPERknee I described to you in '94 was really a rescue knee. Why? It was a knee that had dislocated. It was a complication of lengthening. So the rescue knee is really what you do to reconstruct the knee that's complicated from a lengthening. Okay, but it uses all of these tricks that we just learned, all these components. So here we have a dislocated patella, a rotatory subluxation of the tibia, but we've undergone a lengthening. You see the lengthening of the femur. So muscles are under tension. So we make a lateral incision, same as we've discussed, elevate the flaps, but this is a previously prepared patient. What do I mean by prepared? Remember, all of these procedures that you do before lengthening are called preparatory surgery. So this patient, let's say, was my patient that had already had the fascia lata harvested. Now what do? We don't have a fascia. So this is where I use allograft ligaments. So instead of using fascia, I use allograft. So you can see I elevate the muscle, skin, and you're on muscle. There's no fascia. You decompress the nerve. We've gone through this before, 2 tunnels. You lengthen the biceps tendon, okay? That's taking down the short head, lengthening the long and short head together. You then go to the back of the knee, and you start with the capsulotomy. So you take down the lateral head of gastrocnemius. You go in front of the fat, you get the central geniculate, you cut the posterior capsule laterally, and you work your way across. You cut the medial head of gastrocs, you cut the rest of the capsule all the way. Then you still can't straighten the knee because you have a flexion contracture, but the nerves are short. So we're gonna have to shorten the femur. That'll come later. Next, we wanna expose and mobilize our patella. So we do the Langenschuld. So now we take down the lateral side, then the medial side, then the vastus medialis, and then a transverse incision of the capsule, right? We separated this capsule from synovium. And now we've gone through this, so we're gonna now open the synovium. We elevate the patellar tendon. We do the Grammont procedure. We cut around the synovium, also under the muscle and under the tendon. So now we have a hole in the synovium. And now we do a quadriceps plasty. We elevate the quads. And we go way up. Why? We need to shorten the femur. So we take down our perforators. This is the old lengthening bone. Do you see it? From there to there was where the lengthening was. We go as proximal as possible. And so the shortening is better proximally because you don't end up with a quads lag. So we're going all the way to the tourniquet here. We put a temporary plate here, cut the bone, make a rotational mark, and then disengage the bone. Okay? When we disengage the bone, it shortens. But that takes the tension off the nerves and the vessels. So now, when we've done that, we can come back to the knee joint. Okay? And just to see how much it shortens, when we straighten the knee, okay, when we straighten the knee, where we're stretching the neurovascular bundle, all of the posterior hamstrings, we get that much shortening, okay? So there's no tension in the system. We're just straightening the knee, we get that much shortening. When we flex the knee, because of the quadriceps, we get even more shortening. Whichever is larger is the amount of shortening you're going to do. So based on that, we're going to shorten the second line, and we cut that off. Okay? So you do the flexion and extension test, and whichever one shortens more is the amount of shortening you do. You can now reduce this, but you rotate it if you need to, or you keep it. Let's say there was no rotation, so we keep the rotational line intact, and we fix it. At our clinic, we also use, the artist here has shown the use of a plate. At our clinic, we use a thing that's called a slim rod. Looks like a rush rod, but it screws into the bone at the top. We'll use a combination of the two. So we'll actually pass the rod down here and the plate, and then they stabilize this together. It's stronger, but won't focus on the fixation. So now that we've shortened the femur, we can come back to the repair. In other words, we don't want to do the Langenschuld repair until we can flex the knee with the patella staying centered. Remember, I said that earlier. So in the previous example, we did just the quadriceps plasty. Here we're adding the femoral shortening, all part of the SUPERknee procedure. It's just, so this variation is called the rescue knee. Close the patellar hole in the synovium, mark a new location for the patella, open this knee through the, open the synovium. Free up the adhesions. But now we want to do an ACL reconstruction. So to do the ACL, we want to do a notchplasty. So through that little hole in the patella, we can see the notch. And so we'll hollow out the notch. We've already gone through this, do the notchplasty. And now we're ready, okay? Now, if I wanted to drill my ACL hole, I would have already done it at this point. Repair the patella into place. Okay, advance this. And then we've got our allograft. So this is on the back table. We twist one of these and ligamentize it with Krakow stitches. And we suture it down to Gertie's tubercle. So I like starting on Gertie's tubercle. And then it's like having the fascia there. So we suture both branches right there. And now I can make any ligament reconstruction I want. I can find the lateral collateral ligament, make the extra-articular ACL over the top, pass it over the top, make my drill hole. I usually do that with the synovium open, but it doesn't matter. You can do it closed. And pass it through, tether it on the lateral side with the suture, right? This little extra-articular tether, pull it through there. And then before I fix it, I pass my medial one. Again, allograft. This is allograft going under patellar tendon, around the adductor magnus, all through the same incision, back to itself over the retinaculum, suture it there, and use the biotin screw now in extension, suture the other one to it in flexion, and that's it. So that's the rescue knee. So using all the same things that we just talked about, now we put them all together. And lastly, let me show you 3 more cases and then we'll open it for questions. So now, let's see where this last presentation is. Just 1 second.
Dr. Cherry, please mute yourself. Dr. Cherry, please mute yourself.
Okay, so just to finish, other conditions for the super knee. So this is a boy with congenital pterygium, okay? And he has 110 degrees of knee flexion deformity. Okay, I mean, really, this is his maximum extension. Now, it's hard to believe you can go from this to this in one go. One go. This is a temporary arthrodesis rod. At that time, it was a rush rod and a plate. That's what I was talking about before. He had these previous plates that are fully inside the bone. And I mean, look, this is what we started with. And each one of these we did as one surgery, full correction, acute correction. This is his knee pre-op and his x-ray. You can see it's going to be an archaeologic expedition to get that plate out of the bone. And this is him in his home in Saudi Arabia. That is how he ambulated. That's how he was going to be stuck the rest of his life. So he came to us, what was his age? Let me see. I wrote it up there. No, I didn't. I think he was like 11 or 12, something like that. Anyway, he came to us with that condition bilaterally. Bilateral congenital pterygium syndrome, Escobar syndrome, because he had pterygiae of his elbows, his neck. And let me show you how we did this. So we'll actually go to surgery. So here's, it was good. His previous incision was the same as we were going to use now. He bent his knee well. And so we made this incision from all the way at the top to the bottom. There's the hemoclear tourniquet. That's the amount of exposure we get. We open this. We expose the fascia. And you can see here, that's the medial side right there. You see here's his other leg. He'd already had it. This is pictures from the second surgery. And so there's the iliotibial band. Okay, that's the quadriceps. That's his perineal nerve. These kids, they have a dissociation of their sciatic and their vessels. So normally, you know, the nerves and vessels run together and they're almost at the same layer. These kids, the vessels are way up here and the nerves are here. The nerves take the straight line across. So the top of the fibula is here and yet the nerve is entering down here. You know, some of them have a calcaneoischial band and it's even worse. The posterior tibial nerve runs along the posterior skin. So there's a band called the calcaneoischial band, and right under it is the posterior tibial nerve. So never do a percutaneous release, please, because you'll be doing a release of the posterior tibial nerve. So that creates a problem because you have a severe contracture limited by the nerves. And you can see dissection here of the nerves. And there is the posterior tibial right there, way in the back. So we exposed, let me see. I think I've already taken down the gastrocs there. There's the gastrocs before I took it down. The biceps is already taken down. The fascia is reflected back. Here's the biceps muscle here. And there's the medial head of gastrocnemius. And you can see the posterior capsule. Now that is the femoral vessel. So this is one of the conditions I do find the femoral vessels. So remember, it's in this fat, and there's the femoral vessels from the lateral side. Okay, there's the femoral vein, and the arteries next to it. Okay, so this is one incision and you can get to the medial side as well as the lateral side. And you can see here that is the pes anserinus. And we're exposing medially, and now I'm going to lengthen the various muscles of the pes anserinus, the gracilis, the semitendinosus, and the sartorius. And there they are, and they're going to be cut and Z lengthened. And there's the medial gastrocs, seen there. Okay, there's your medial gastrocs right there. This is the semimembranosus, and we're taking that down in a Z fashion. And now we're in the back of the knee on the medial side. So this is an even more extensive super knee procedure. There's the gastrocnemius tendon taken down. And then there's the vessels. There's the femoral vein. The artery will be with it. And you can see here, what is that? That's the posterior tibial nerve, I think. Here's the vessels. And again, taking them down from the back of the knee joint. And you'll be able to see right across the knee in this case. So again, staying on capsule, preserving all the vessels. In younger children, you also have to, there's vessels going from these vessels to the distal femoral epiphysis. You cannot take those down. Otherwise, you'll get a vascular necrosis of the distal femur. So you have to preserve all the small vessels going into the epiphysis of the distal femur. And then here's opening the capsule in the back of the knee. Now we're exposing the femur, and you can see his previous plate and removing that plate, which was not fun. Let me see where, moving forward so I can show. Okay, there's where you can see across the back of the knee joint. So this is the most extreme example of what we're talking about. These are the vessels here that go to the femur. See how I've left them intact? So these vessels, this retinaculum, goes to the epiphysis of the femur. And then we've broken the femur. It kind of broke where we were taking out the plate. Didn't have much choice there. So we overlap the bone ends. There's one bone end. There's the other bone end. This is where we broke it. And do you see how much shortening it requires? There's the mark on the femur. 5 centimeters in this case. So we removed that segment of bone, put it together. Now we're drilling a wire up the canal in a retrograde fashion, antegrade fashion. We actually put a rod inside the bone temporarily from the greater trochanter down, put the plate on so that it doesn't hit the rod. So the rod's already in there. And then we restabilize the femur. But now the knee's fully straight, you notice. And we did one side and then we did the other side. This is him in follow-up in our rehab department. You can see what he's able to do and him walking down the hall.
All the way, make it hit the knees. Yes. Make it hit just big.
And that's the results.
Yes.
Now, one of the things that we did in this guy, just to go back, I want to show you the x-rays. Now you'll appreciate what we did. We put the rod, which in this case was a rush rod. I'm going to go all the way back, sorry. No, where's my post-op x-rays? There. We put this rod all the way through the knee. So this is a different method of doing temporary arthrodesis where you do it antegrade. So we put this rod across for 6 weeks. Then we came back, took the rod out, left the rod in the epiphysis. In other words, we shortened the rod to protect the femur from breaking while you do the therapy. So rods are very good to protect the femur. So 6 weeks, the full rod, and then after that. And that way we don't lose the ability to fully extend the knee. Okay? So that's the part that you kind of didn't see in surgery, but I'll skip all this and come to the next case. So again, this is a extreme super knee applied to congenital pterygium. Let's look at this next case. This is a girl with neonatal sepsis. Okay, it's non-congenital, but we're going to do a super knee on her. She develops flexion deformity of the knee, more flexion deformity of the knee. Nobody does anything. Okay. She presents to us at age 15 with that deformity, 90-degree flexion deformity, both knees. This is her trying to walk in our clinic. Okay. I mean, she needs to lean on the wall. She gets very tired because try walking at 90 degrees with your knees. See how far you get. Not very far. So she uses a wheelchair most of the time. That's what she came with. Okay, severe flexion deformity of the knee. But this is neonatal sepsis, non-congenital. And she's got these femoral condyles that are facing each other, called the fishtail deformity. The real articular surface is right here and right there. There's no intercondylar space. And distal femur is flexed, proximal tibia is flexed, and there's flexion contracture. So this is the analysis, PPTA 61, PPTA 64, PDFA 61, okay? So she has, you know, about 22 degrees of distal femur flexion. She has about you know, 17 degrees of proximal tibial flexion, and the rest of it is due to contracture. This is a 3D. Look at the back of the knee, so you can see how the femoral, there's no notch because, and the articular surface is this. This space, interestingly, you know what that's filled with? The popliteal tendon becomes the thickness of the Achilles tendon, and it becomes articular, it becomes weight bearing. So it sits in this area here. So how do you treat this? I mean, this is really, you know, can we treat, and there's the flexion, the increased slope of the proximal tibia. You can see the flexion of the distal femur, okay? And so, and we went ahead and we split her femoral condyles. So we did an intra-articular osteotomy. Now we're adding one more layer to the SUPERknee, okay? We split it and came out the lateral side, okay? And then widened the knee with a laminar spreader. This is all through, you know, just a tiny incision in the front. And then we put a compression screw, a lag screw here, and a fully threaded screw here, okay? And then we complete the osteotomy in the supracondylar region and put a plate on to realign it, extending the distal femur and realigning any varus valgus that there is. So widening osteotomy, intercondylar, intra-articular, and then extra-articular osteotomy in the supracondylar region. And in the tibia, it was an extra-articular extension osteotomy also, I think, varus or valgus, I don't remember. We ended up doing both sides and a posterior capsulotomy, all in one operation, one side and then the other side. So 2 separate operations, 3 months apart. That's how she walks now. No temporary arthrodesis of the knee on this one.
Come on back in.
Immediate rehab after surgery, life-changing.
And turn to the side. And bend your knee.
And she's much better than this now. This is, you know, her at the beach, her running at school, you know, so life-changing. And the last case I'll show you, again, intra-articular, Ellis von Creveld. You know, again, SUPERknee. Why? Because he's got a dislocated patella. Okay, so his patella is somewhere out here. He's got a depressed lateral plateau. He's got a hypoplastic fibula. Okay, so what do we do here? We expose the peroneal nerve. It's the ultimate release. We actually remove, we cut the proximal fibula, take down its proximal tib-fib joint so that the peroneal nerve can actually go behind the fibula to get enough length. And then we elevated the plateau. You can see here the cut. After lengthening the iliotibial band, biceps tendon, releasing the nerve, taking down the fibula with the lateral collateral ligament. Okay, elevating it proximally, keeping the capsule closed, and doing a distal femoral osteotomy. Okay, and this is what his legs look like. Okay, after one was done on the left, not on the right. And then I repeated the same thing 11 years later. He disappeared for a long time. 11 years later, I did his other side. Release, soft tissue release, elevate the lateral side. The pins are already ready from the medial side, the drill bits. When you elevate the lateral side, you drill across and then you put the pins in. Bone graft that. And then here's his fibula separated from the tibia with the lateral collateral ligament. Okay. Let the peroneal nerve actually come through the two in the space between them. So hopefully no one will ever go back to look for it because it's not in the, it's following the anterior tibial artery, and then put it back at the correct tension. And we did an acute correction with an opening wedge laterally there. Nerve stayed intact. So that's kind of the end of my slideshows, but